All right, we are recording.
Okay, so Tasia asked me to do like a little bit of education on what we do from the ER standpoint when y'all bring a stroke patient to our facility. But before we got started, I had found some education online on the UAMS side that I just kind of wanted to go over. I mean, I know a lot of y'all have been doing this a long time, but it just kind of talks about the stroke program, where it began, why it's doing what it's doing, and found like a little slideshow here. And I'm just going to kind of scroll through some of these slides so we can kind of refresh here. Talks about how the stroke program, of course, we all knew it as AR Saves at the time, started in 2008. Tim, do you remember whenever we got it here at this facility?
Stroke.
Because I know Tammy started it, but I can't remember like what year.
Trauma we started at 11. I think it's like 16 or 17.
That sounds about right.
She could tell you if you really wanted to know.
So the program started in 2008, and whenever the program very first started, stroke was Arkansas was #1 in the nation for stroke deaths, which is a bad number. #1 is not a good number that you want. So and now I think we're number 11. Yes. Arkansas is currently number 11. So that's a huge thing, and AR Saves has proven that they really made a difference in stroke care. So I wanted to, for sure, all know the stroke stand and talks about community education and why it's a big thing. We'll talk about that here in a little bit. I was hoping that
So we're just still. I know the answer to this, but I'm just going to ask it for goodness sake. We're still just doing trauma calls on trauma calls, we're not doing stroke calls, correct?
No. Okay. So do y'all, whenever y'all have a trauma, you call it out on the field?
Not up to measure.
Okay. Of course, I was gonna say, of course, you know, the quicker you can call for stroke, the better the ER. But I know y'all are limited on service and everything. But
at one time they tested. We would actually call, was it TraumaCom for strokes, and they would give us the same thing, but that went away. That was just a test thing.
Okay, so that's where I'm getting that from.
Yeah, that was a test
Okay.
thing. That didn't last long because I would try to do it a couple of times, and they reminded me, no, we stopped doing that.
So that picture I showed you, that bird picture, they suggested second and third degree burns. They suggested we come here. What?
Well, that maybe because they know you're not going to stay,
It was stable.
because you're going to go to end up at Children's if you're in Arkansas.
well, and you know, TraumaCom used to, back whenever COVID was real big, they navigated ICU beds as well. So, and they don't do that anymore either.
Oh.
So, I mean, they're strictly trauma.
Okay.
In y'all's packet, there's a paper that, this is what I was looking for. It's got all the sites on it, which I know y'all all know. Cherokee Village, of course, is a site. Baxter is another site. And, of course, us, which, of course, Missouri does not participate in the AR Saves program. They have their own form of something. I don't know exactly what it is, but they have the neurologist there, but she's not there 24/7, so that's a big deal for them. Okay, so that's kind of just a little backstory on the stroke program, and then as far as when the patient comes to our emergency department, and Amanda is going to talk a lot more about this when y'all are in the field, so I'm not going to hit on it as much on the 24th when she's here. But of course, some big things whenever y'all are picking up a patient that potentially has had a stroke. For one, please don't ever hesitate to think that it's a stroke. If you have any doubt in the back of your mind that it could potentially be a stroke, let's go ahead and start the process. I mean, that's not our place to diagnose the patient. It's our place to see what's going on. And like I said, if you have anything in the back of your mind, I trust you guys. Y'all have been doing this a long time. And I'd much rather us call it off as a code stroke, quote unquote, than them get there and the process hasn't been started. Because when we get that pre-notification time from y'all, it means so much. We're able to get a lot of things done and get them ready for that patient once they arrive. So finding out, of course, their medications that they take is a big thing. I know y'all know this, but if they're on any kind of blood thinners, it can exclude them from getting the tea in case medication. And then also that last known well time, that is so important. I mean, if we don't have the last known well time, it can also exclude the patient from getting tea in case. I see y'all are passed around we don't use that anymore. That's the Activase. Now we're using the tea in case, and it's a IV push, and it's just ×1, and so there's no drips or anything like that. So it's really good. Okay. So that one was you give it the IV bolus, and then you hang the drip. And now what we're using with the tea in case is just a ×1, and it's done. Okay. Yeah. So that we'll get more into that whenever later, but anyway, so that's kind of obsolete. We actually don't even carry that medication anymore. So I can throw that away. Yeah, you can throw it away because we have a spare one just in case if we ever had to go back to it. We still have all of the paperwork, and if we had to go back to that, something happened, tea in case was off the market for a second or whatever. So I mean, yeah.
Well, I'll keep it then, just in case.
I was gonna say,
go back to it was just in that stuff up in that closet when I took everything out.
Okay. Yeah, I was gonna say we have some extra bottles in our little education area as well. So with the tea in case, I don't think I gave y'all any handouts on it, but like I said, it's just a ×1 and done, and y'all can kind of pass this around. It goes over like the weight dosages and everything for that and how much to give. Of course, the neurologist and the ED doc, they're gonna verify what we're given and how much of it. And then once we give it, their patient could just be saline lump if you want to pass that around. So back on what we can do out on the field. So last known well time. I mean, and a lot of times people will give us what they think is a last known well time, and it's not really a last known well time. We need to know when the last time that patient was seen when they were absolutely at their normal. So Papaw got up and was getting around making coffee. Mamaw saw him while he was getting up making coffee. He was using both of his hands. He was walking fine. And then she goes to the bathroom and she comes back and Papaw can't lift his right arm. So when Papaw was making coffee, that was our last known well time, not the time that she saw him when he wasn't able to use his arm. So that's a real big thing. And the neurologist will hound us on the last known well time in the story, what the storyline goes. So
are you having a stroke?
Yeah. I don't even know what that was. A bunch of balls. So if the patient was last seen well prior to falling asleep that night, that's another big factor, because that can exclude them as well from getting the tea in case. Of course, once we get the patient to our emergency department, we are going to immediately go to CT. If they come in for y'all, that's one of the great things is we know they're coming. We can try to get some information from y'all, date of birth, name, whatever you have. Try to get, if they've been here before, of course, it makes it easier because we already have some information on them. With the Baxter system, we have to have a little bit more information than we did before. Before we could just put John Doe in and scan them and get the information later. But now we really need as anything that we can get, like I said, the date of birth, name. Now we can even kind of look at their addresses and different things. So whatever y'all have, whatever you can call in, that would be great. Let us know as soon as you think it's a stroke. I don't care if you're 30 minutes out. Go ahead and call, say, hey, this is what we got. This is the process we're going. They're on blood thinners, they're not on blood thinners. This is our last known well time. This is their symptoms, and we're coming to y'all. We don't know exactly what time we'll be there, but this is the name and the birth date, whatever. We can go ahead and get them, like I said, get them registered, start looking up if they have been here, looking up their history, things like that. Y'all get here, we're going to immediately go to CT, and a nurse needs to be going with EMS to CT. If y'all have any issues where a nurse is not going with y'all to CT, let me know. Because I want that stretcher back there. I want us to be able to take the patient off of y'all's stretcher, put them on that CT table, scan them, and then put them on our ER stretcher. And that's the process we would like to see. Of course, sometimes that can't happen. They're busy, whatever, but in a perfect world, let's try that.
I haven't had any problems. Everybody's been great.
Okay, good. So get them scanned. Of course, now we're doing the head CT without contrast and the CTA with contrast. So CTA head and neck and the head CT. The reason we're doing that CTA head and neck, that's a new thing that we've started. Baxter, UMS has been pushing that for a long time. But if they have any type of a large vessel occlusion, that can put them in a window if they're within 24 hours of having a thrombectomy. So, and they can also get the T in case and have the thrombectomy as well. So, we're getting the head CT, the head CTA, head and neck CTA. Coming back to the ER, of course, radiologist is going to push those images to the repository. Okay, so the neurologist that's on call at UAMS, or I think the Washington Regional, they have one as well. That neurologist can be looking at those images. Okay,
So
and
or is it?
well, our radiologist is going to look at it as well, but the neurosurgeon is going to be, that's on call. They'll be wanting to look at those images because hopefully the nurse has already called. Once somebody's back in CT with the patient, the nurse has already called, getting the process started on saying, this is what we've got. This is the patient. We have a form we have to fill out. We have to have certain criteria and certain things for them. Going ahead and getting that faxed. And then that way the neurologist is already knowing that they've got a potential consult coming. Something I didn't mention, which I know all y'all know this, but of course, if their symptoms are greater than 4.5 hours, they're out of the window for the T in case. Now, they could potentially, though, if their symptoms are greater than 4.5 hours, but less than 24, they could have that thrombectomy. So that's one of the reasons we're getting that CTA of the head and neck. All right, so we're bringing the patient back off the stretcher, or back from radiology. We're going back to the ER. Some things that you can help us do potentially if y'all aren't super busy, getting them hooked up to the blood pressure, cardiac monitor, putting them on or seeing if they need any oxygen, putting their SpO2 finger on, getting it, if you haven't already, which y'all are really, really great about this, is getting that blood sugar. We've got to have a blood sugar because there has been times when we've had patients come in and they've had stroke-like symptoms and it was their blood sugar. So, and UMS absolutely will not let us start a consult without having a blood glucose. So if y'all get one out in the field, that's great. We use it. So I trust y'all's judgment. If that's what their blood sugar is, we're going with it. And then that we don't have to do it once they get here. So we need at least 3 blood pressures on the patient once they come back from the ER, because neurologist is going to ask for that. Okay. They're going to want to know that blood glucose. We're hoping that y'all drew blood out in the field when y'all gotten our two IVs. One of the big things about the whole IVs is, of course, once you give them that blood thinner medication, you can't stick the patient anymore. No type of invasive procedures. They really don't even want you to put a catheter in. So if we can go ahead and get our IVs and get our catheter in and all that stuff before we give them any blood thinner, that's great, because of course, if they're going to have to go anywhere, it makes it easier on y'all for transport.
So your blood pressures, is it 3 documented blood pressures, or is it 3 that has to be done by you?
They don't have to be done by us. Y'all can do 3.
Okay.
Usually have 2 before we get
Yeah.
Yeah.
So do you want us to try and start 2 lines?
If you can. If you think it's a potential stroke and they're in that window and they may be getting the T in case, that would be amazing, because I'm one of those type of people. I'm not going to just stand back and not do anything. If I'm waiting on UMS to call me back or whatever, I'm the type let's go ahead and get 2 lines. Let's get the catheter. Let's get them packaged.
Sometimes you can't, obviously.
Right.
Let's say you cannot go on. Is it acceptable to do an IO? Is that
Or a cord?
be in case?
If they have a port, you can give. I don't know if you can give it through an IO. I would have to ask.
I don't know. That's what that's.
I've never had that. Yeah.
I mean,
Have
there
that
are some patients that very difficult to get out of.
Oh yeah, I know. If you can get one IV, I mean, whatever you can get, of course, we're gonna take it. With that CTA of the head and neck,
Mhm.
they really want a 20 gauge or larger, of course, because you're pushing that contrast so fast. But whatever you can get is what you can get. I've been there before. I mean,
You got one or two that you can't get anything but like a 22 right here at the hand.
We need to start exercising EJs.
I would love to see an EJ. Like,
They're not-
I would love to too.
Well, they're not hard to do. But,
Yeah.
It's very easy to do work.
Because
If
see,
you know how to do the catch, follow your guidelines and.
as far as nursing, we're not allowed to do them. So if y'all can bring one in with that, or if y'all get them there and you think you can get one, let's do it. I mean, it's gonna help the patient.
So does it matter affected or unaffected side? If we're doing IVs, we can do either.
Either.
Okay.
Yeah. So when we're doing a actual call, they want us to be on, I think they said they want us to be on the unaffected side. So, are you laughing at me?
No.
No,
Balls
Okay.
are coming
my
in.
balls come
Oh
out.
my gosh. I can't remember exactly if they want us to be on the, but if you have the IV, of course, we'll have to put the blood pressure cuff on the other side. So, I mean, but like I said, wherever you can get it, just we're gonna get it. So we're not gonna discriminate here. Okay, where were we at? So we've come back, we've got our blood pressure, we've got our AccuCheck. And then hopefully the nurse is calling and getting UAMS on the line. We also, if they can't get up to weigh, we've got to have an accurate weight. So reminding the nurses, hey, is that a weigh bed? Because we have some weigh stretchers down there. Of course, in the thick of things, nobody thinks about that. And, and then we don't have a weight on PAP off. So if you can think about it, remind them about that. Or if you have a weight, like they just weighed the day before or whatever, that's what Mamaw said PAPAW was, we're gonna go with that too. So just as accurate as we can get. The nurse is calling, okay, and so from our standpoint, this is where things start to really pick up, of course. And once we do that NIH exam on screen with that neurologist watching, of course, the neurologist might ask us to do certain things or skip certain parts of the exam because, you can clearly tell he's flaccid on the right side. So we are speaking with that neurologist, the ER doc's in there, the blood's hopefully in the lab. We're starting to get some labs back. Of course, their PTI&R, if there's certain things that are off, they're not going to be a candidate for that team case. So
PTI.
that's the blood clotting studies. So if, sometimes we might find out that they are actually on a blood thinner when they say that they aren't, or, something else is going on. So they're very strict on those labs, that they're even just a little bit off. So, and when I talk about having the blood in the lab, so if y'all can get an IV and can get blood in a perfect world, you're able to draw a rainbow. Say you bring it in with the patient, that's great. We can just send that to the lab. If not, that does kind of hold up the process a little bit if we can't get blood, just because they're not going to give T in case unless they have those labs back. So that's an absolute. So, yeah.
For what it's worth, I just looked it up. IO is acceptable use in case.
Awesome. Thank you for that.
So you said 20 or higher. Does it have to be AC and higher, or is it anywhere?
We'll take it anywhere.
Okay.
Yeah. If it flushes good, the big thing is that contrast has to go in so fast. We don't want to blow our IV, of course, with the contrast. So they like for it to be the AC or higher, but if you've got a good one in the hand and you can get it and it's gonna flush and it's gonna draw, do it. Okay. So our blood's in the lab. I think where I was. The neurologist is saying, okay, we're going to give this team case. So some things that y'all can help us with is having the stretcher here ready. If they're potentially a candidate for the thrombectomy, of course, we want them on the road as quick as possible. If we could fly, that's great. If the weather's perfect, there's not a cloud, let's do that. And that's what they want you to do if they're potential for a thrombectomy, because they, of course, want to take them to the cath lab ASAP. So if they can't fly and we're going to have to go by ground, of course, being here, being prepared, already knowing what's going on, where the story's coming from. You know, if y'all were the ones that brought him in, that's great. If not, trying to kind of find out what happened. We are very, very, very blessed to have y'all, because I know a lot of other trucks would not do stuff for us and help us like y'all do. And y'all are great, and I can't say that enough. So, but that's kind of like from an ER standpoint what we do. Do y'all have any questions about that process? Last known well time, knowing the story. If there's any way there's somebody that was in the house that witnessed this, that knows about the patient, knows their history, send them to the ER as soon as possible. Get them on their way. It's going to take them longer to get there than y'all. So if they can get here, go ahead and get them start, you know, signing them in, registering them, whatever. Start talking to the nursing staff. So that way the nurses kind of know a little bit more history. I'm telling y'all that pre-notification, they've done studies on it, and I'm sure Amanda will talk about it. But when patients come in via EMS versus private vehicle, they're able to get help so much quicker. And she'll give you the exact statistics and everything. Yes. Y'all have already started the process.
So our windows, I know it's really important to get time, but we're talking about when Papa's alarm went flashing, when Papa was able to drink coffee when he first got up in the morning, 7:30. How far back? I mean, if it's like last known, what, like our guy, the burn victim was last seen 5 days ago. Do you need a time? 8 o'clock,
If
5 days ago?
If it's over 24 hours, that's all we need to know.
Okay.
Because like I said, the 24-hour mark is our mark for our large vessel occlusions, potential thrombectomy. So if you're 24 hours or less, I would know an exact time, you know, but if it's 24 hours or they were last seen 2 days ago, that's all you got. I mean, and they're not going to be a candidate for anything. Mm-hmm.
That's good to know.
Yeah.
Sometimes it's hard to get it nailed down. Like, oh, well, you know, it was today. Well, what time? Okay, well, I don't remember. What was it? Breakfast? Was it? Yeah, it was when I got up. Okay, well,
Yeah.
what time was that? You know, I don't know. I don't recall.
Oh my gosh, it is so frustrating. I remember when we very first started this program, like there were so many times I'd be like, what's the last, and I would get so pissed because I'm like, we have got to know the last normal time, but also I get it. We're all human. Mama and Papa, they live day to day at the house and they don't think about the time.
No.
Yeah. They don't even know what
Really good
day
thing
it
to
is.
ask them.
And you've got 4 family members who give you 5 different stories.
Yeah.
Oh, yeah.
Really good thing is to ask them if they made any phone calls throughout the day.
Oh, that's a good thing. That's a good idea.
Because then they can scroll back and be like, well, I talked to my doctor this morning at 8 o'clock
Mhm.
this morning, and then when I got up. So those kind of indicator of what time.
That's awesome. Yeah.
I've used it before, that's why I know.
So last on well time, medication list or bag of meds, if you've got them, you go ahead and grab that bag of meds. Y'all can start looking at them once you're in the back of the truck and letting us know if you see any blood thinners or anything. EMTs. Getting name, date of birth, we can go ahead and get them in the prop, like start checking them in. Yeah.
I just want it to be known,
Oh, boy.
I don't take blood thinners any longer. So,
And the last on well time was 30 minutes ago, and we
Yeah.
saw you normal.
yeah, give it to me. I don't want
Yeah.
to drool on my pillow for 40 years. Well,
Mhm.
20 years maybe. I'd rather die of a bleed.
Yeah.
But I get it. I'm just,
And I mean,
not really.
Honest. You're just being
I
honest.
want the thing. I want it.
Yeah,
yeah.
I do.
So you're entitled
No,
to
as compared to being a vegetable.
They're gonna test you for a bleed before, that's what that CT is for. They're gonna clear that before they give you any blood thinners anyways, so, or the T in case, I say blood thinners, but, so they're gonna clear you for a bleed from that. Now, of course, there are risks whenever we give T in case of them potentially bleeding, but, so, in y'all's packet, I've got some, it's like our, kind of a little, it's basically a protocol. I know y'all are a little different, and Dr. Bozeman signs off on your things, but it's just like a little protocol of what to do in the back of the truck if they've been given T in case, and kind of what we like to follow, the medications we like to give. And so I know every ER doctor is different,
Oh,
and they're all
yes.
stubborn as hell, but.
Is it page 20?
Hold on.
Sorry.
Yeah.
I don't know, it's his June.
Which one is-
What is it? The paint?
What page you want?
Did I not put it in there?
I'm on page 7.
Is it
Oh.
page 7? It's 20.
It's 20.
Yeah.
1332.
20.
Yeah.
It's not the actual.
They're not in
page,
order.
That's what it
I'm
says.
like,
Oh,
wait a
it's
second.
towards the back.
Because it's 32 and.
Yeah, it's not in order.
Do you want this posted in the Drugs?
I'm also confusing.
It wouldn't hurt. I think one thing, sorry,
No, you're fine.
we probably need to laminate everything before posting.
Yeah.
Or I'll make you a new copy of
We're gonna
this,
sign
so
it.
that way you
Thank
got
you.
it, I'll get it laminated.
We're gonna do a binder with all our report stuff to flip through.
Within the protocol.
Yeah, because I mean, you keep putting more stuff on the walls, it's gonna look bad.
Yeah, but.
Yeah.
Well, I don't worry about that. I mean,
Well, I stopped reading it when there's too many.
well, I mean, but if you know it's there.
Yeah.
No, you got a little
It's a
binder
stroke.
that says stroke
Right,
protocol, you just open it up.
As long as we don't,
Yeah.
the
Not like we
binder
got-
doesn't get removed and placed in a cabinet 3 different times in 3 different places,
We'll talk
which,
about it later and vote.
yeah.
I thought Procardia was something you need to use it for.
We don't even have it.
But either one works as long as we all know where they are.
Procardia. Okay.
Labetalol is the big drug that we give.
I don't
Of course, our
remember.
blood pressure starts getting out of
Very
control.
great. No.
And another thing that UMS has really been hitting on us about is we'll still be on the camera and we'll get done with doing the NIH stroke scale. And Papa will ask for something to drink. And of course, we're all sweet Southern belles and we want to give Papa something to drink. We'll go get him something to drink. And they're like, absolutely not, nothing by mouth. If he's potentially had a stroke, of course, he needs a swallow study before we start giving him anything. So we're pretty bad about that. So for y'all back there.
Yeah, is thirsty.
Every patient, or they need to go to the bathroom,
Yeah.
or it's like.
And as soon as they say they're thirsty, I am.
No, but I gotta do it myself.
And
I feel guilty. With the man back there in the back.
She slurps it.
this page, number 32, it just kind of, that's our form that we have to send in. We fax that to the call center whenever we have a potential stroke. And that was just kind of for reference for y'all, kind of let y'all know what we have to have for them. Also, the page before that, that 13, it's the exclusions to call. And that's kind of a little interesting thing. I'm not gonna read that, so I know y'all can. One thing that really does piss me off, though, I will say, is when I have staff that are trying to get out of work, and that's what they're looking at. No, we're gonna take care of the patient. You know, if they potentially could get TNCase or get care, we're gonna call the call center. I'd rather you call the call center than not. So don't look at the exclusions to call to get out of work. Look at it to take care of the patient. That's what I ask.
As of late, my run-in has been previous stroke patients showing
Yes.
symptoms.
Oh, yeah.
And so when you do your stroke scale, it's already non-conclusive because.
Yeah, previous.
Yeah.
episodes.
Or,
We have
Yeah.
had a lot of strokes lately and a lot of repeat patients. I agree with that.
maybe that's because we're doing a good job since the first time.
Yeah.
Yeah.
Well, and a lot of patients that, they'll wait so many days and it's like,
Yeah,
what in the
it'll get
world?
better.
Yeah.
So, and then that goes back to the community. So what are we doing to reach out to the community and teach them?
So we're required to do 2 types of education each month for our stroke program. One of them is called active education, one of them is called passive education. So any kind of active education, that's me coming, talking directly to y'all, certain amount of people. We're talking about stroke, we're talking about things to do. And then there's called passive education, which is me putting some flyers out on this table, y'all coming in for a different class, not stroke related, and just picking up a flyer. So I have to do one of each of those. And that is another thing I was gonna ask y'all today. If y'all know any first responders, any kind of event coming up, we are always looking for places to go out and do education.
I'm looking at summer for boys, for firefighter boys.
That would be great. I don't necessarily know when everybody's doing their stuff. I live in Byron, so I'm the Byron Fire Department people. I don't know when Salem's doing things, and so if y'all know of anything, please let me or Erica know, and we would be more than happy to come out, talk to people, bring some stress balls. I mean, just whatever. So
You only do Fulton County?
we can go outside of Fulton County now. Say it's Baxter County, I would just probably call Tammy and be like, hey, we've had somebody reach out to us from that area, and Tammy and I could go together.
Because I want to find out.
Oh, we could do Pineville, yeah. I don't even know if, is Calico even part of the stroke program anymore?
Not in the list.
According to
It's
the
on the
list,
list.
it is.
According to
I don't
Tammy,
think
it's
that, I
not.
think that that's outdated, because I don't think they
She
are
told
either.
me that they are no longer part of the stroke
Really?
system.
I know every time I went fix one up, they either go here or MCD.
I can ask her, but I know she told me that the other day. We were talking about teaching this class. She was saying that Calico was no longer part of the, they're definitely not part of the trauma system.
Yeah, I was gonna
But I
say.
think I'm positive she told me they're no longer part of the stroke, Arkansas stroke.
Okay.
You need to
Okay.
ask her. I mean, I don't care.
Yeah, text her and ask her and see if she knows off the top. I could look it up on my computer,
I'm
but
almost positive she told me that.
But Cherokee, that's probably.
yes, absolutely. Cherokee is. Another thing I wanted to talk about is, so I have to do like a QA type process on each stroke patient that comes in. And some of the things that I have to look for is, of course, their mode of arrival. And if they came in by EMS, did y'all stroke band that patient? Don't be afraid to stroke band a patient. You put it on and they're not a stroke, it's fine. I mean, we'll document it, we'll move on. But if y'all put the stroke band on, if y'all gave us pre-notification when you came to the ER, we never have issues with that with y'all, but did you do it? Yes, no. And then also when you call, they call it code stroke, but if y'all say, hey, it's a potential stroke, that's code stroke does. Like that's, if you say anything about stroke-like symptoms, whatever, that's already going through our brain.
Trauma date is correct. It's like a fall.
Yes. Mhm. Yeah, I mean, if they have a stroke band and a trauma band on, it's not gonna affect us any, so we'll just document it and move forward. And a lot of times, and I've seen this a lot, especially because of course I do stroke and trauma, but they'll come in and you'll think it's a stroke, and then I'll start looking through the history after the patient's done gone, and I'm like, actually, this was a traumatically, not yeah, so. Okay, and did y'all document the last known well time? Did y'all tell us when the last known well time was? And was a BFAS exam performed by EMS? Now, do y'all have like a certain exam y'all do? Okay, I was gonna say, did y'all do it or did y'all not? Yes or no?
And we will be learning, we're gonna, on one of the days, we're actually gonna go down and watch a mock in the ER. So,
Yeah, that's the day Amanda's coming.
yes.
Yeah.
Yeah.
Yeah, because Robin's coming as well, Robin Banks, and she's gonna be.
I did part of the
doing this
mock
stuff.
once, that was fun. Yeah, yeah.
Anytime y'all can be a part of that, that would be great, because I mean, it's just kind of letting y'all know what happens and what our process is. And another thing is, don't be scared of it. Like, get educated, figure out how to do it. That way, and that's why I tell the nurses down there, they're all so terrified to do mocks. And it's like, why be scared? Like, as long as you know what you're doing, it makes the process so much easier when you have an actual patient there. So, and I was there too. I was the one that was scared and didn't want to do it.
The 28th of March.
You don't know something, okay, but that's what we're doing.
Exactly. We're required to do 2 mocks a month. What is this, David?
This is something that, is aspirin an absolute contraindication or is that a relative contraindication?
For the T in case?
Yes,
I don't think it is.
because it's always,
That's
you always get that
yeah,
that's a
look it up.
contraindication, but I'm like, is it relative or not? I mean, is it absolute or is
In
there?
that case, I want to join Tim, and I do not take an aspirin every morning. So,
Yeah, he says, don't have to aspirin, Flavin.
Cause it's on all
So
the
on
list.
our exclusion criteria, they don't want us to give aspirin after they've had TNKs. But on our exclusion criteria, it says, use of newer anticoagulants in the last 48 hours, Pradaxa, Xarelto, Eliquis. And, we're gonna get that PTINR. So of course, if they're on Coumadin, we're gonna catch that. So, no, aspirin is not.
Aspirin's not really a blood thinner. What it does is it prevents the clotting factor,
Yeah,
the fiber.
but I'm like, if it's
That's
something,
what
you
it
always
does.
see it on the list, and I'm like, is that really? Cause
But it's not a
Would
blood
it be
thinner.
helpful to know when they, like, if they had their meds, like their morning meds, their evening meds, or when they had their last aspirin? Would that be beneficial?
It would, but I don't want y'all to get too far down in the weeds. Like, I just want you to, you know, are they on blood thinners? Are they not? And say if they've been off of their medicines for 5 days because they're having a procedure, that might be something different. Yes, but I mean, because on our exclusion criteria, it says within the last 48 hours, and more than likely, Papa's gonna have done taking it. Like I said, unless he's holding off on something.
We have 300 radios in here.
So
My radio's off, I can't go.
okay, so that's the QA process that I do. And then, okay, let me see if it's connected back. Not. So I wanted to show y'all the learn on demand. So the other day, Tasia, I was talking to you about that, and everybody, it's free and it's education, and y'all can use it for EMS CEUs. I know it's not a whole lot, but
Hey, it helps. You sent it to me, didn't you?
I did. And I also put it in the very back of y'all's packet. There's learn on demand information
Took such good care of us. Thank you.
on how to log in. If y'all haven't already,
oh, there it is.
I'll try to remember. I texted
I
this
know
one.
whenever I got on there before I came back here, because I was just kind of looking around for y'all. I know there, I found 1 hour of EMS CUs on there for free. It's not gonna let me connect, but it's okay. So, because y'all have your information.
That's actually EAMS, isn't it?
It is. Yeah, and there's a lot of different education. Now, I don't know necessarily all of it is for your CUs or whatever, but
Well, they're actually, I don't want to say they're going lax, but if it is anything relative to EMS, nursing, respiratory, they accept it. They're accepting like podcasts and stuff now.
I would say they're desperate to keep people in the EMS.
Yeah,
yeah.
so which is, I think it's beneficial because, I mean, we see, but we don't know what goes on your side. And like, we learned a ton from Rhonda in here earlier that wasn't really specifically EMS related,
Yeah.
but it's good information to know, because it really helps us take better care of our patients.
I'm looking forward to Amanda coming. I hate it's not Tim Vandiver because he's retired now, but he was great. She's taken his spot, and apparently she's stepping into his role pretty well. And I've not met her yet, so I'm excited for her to come and talk to as many of y'all that we can get here for that. If we need to go to the big conference room, we can to make.
So is she
room,
gonna
whatever.
be here?
Yeah, she's gonna be here.
Good.
So, and that's a great talk. I've listened to Tim's talk that he does, so but that will be great for EMS. It's great for first responders, I think, too. So,
Well, we may just have to move down to a conference room as many as what we have today. Might just need to make 21.
So, you said that,
Tomorrow.
for a nurse to
Me,
be done.
tomorrow.
Tuesday, Wednesday.
Wednesday.
we'll have to follow y'all to CT.
Okay, what's there's already a bed
Maybe we
down,
get an ambulance.
and you guys are busy up here.
Oh,
That's if there's already a bed down there, and y'all taking them to CT, and everybody's busy. Just go ahead and put them on that ER. Find out while they're getting scanned. If one of y'all can step in, just find out where that you want the bed pushed to, and then just go ahead and push them in there, and go ahead and start hooking them up to the monitor if you don't care.
No, we don't
That'd be
have-
great.
I'm more looking on-
I got you back on.
Well, getting them, go ahead and just, the least you have to move them around, the better, and I mean, that's what I,
About 2 weeks. When I said that.
so. No, I'm not taking up all of my time. I'm supposed to be long.
Been there,
but
done that.
is there anything else, any other questions that y'all might have? I did have like a little, if you look at UAMS stroke program, there's all kinds of resources on there, and that's what I was gonna show y'all on here, but y'all can get on there on your own, but it has like different patient stories that have had, and I was gonna show y'all one, but it was actually a physician at Salem Memorial when he was having a stroke, and it talks about his process and what happened, and the type of stroke he was having, I want to say it was like a brain stem.
Mhm.
I can't remember. It's like one of the real rare ones. It was where he felt like he was so dizzy, like he was like grabbing the sides of the rails of the bed, and on his exam, it shows him just like holding on for dear life because he's so afraid he's gonna fall. But and he was able to get up on stage afterwards and give his speech. I think that's pretty awesome. I love listening to the patient stories. So he made the comment in his little talk. He said, "I was stupid and I didn't call EMS." And Chris, now we have all the documentation that shows it's such a great thing, and it gives us all the pre-notification we need. But
with the basilar ones like that, I think I've seen 3 or 4 of them now. So they can talk to you, they can answer everything. Well, if there is an exception, we did have one that could. The other ones can talk to you, they can do everything except the balance center's locked up. They cannot stand up for you. And even if you lift them up, they will immediately go back down the chair or whatever they're in.
yeah, that might have been bad. I can't remember. It was a really weird one.
They can do all the other stuff. Part of them can. But the balance center's shot.
Or they've got inner ear problems. It's one of those. Or they've got inner ear problems. It's one of those.
I know vertigo is like such a pretty common thing. So,
Oh,
but like that's one of the things though. Like
You
if,
never know.
if it's a sudden onset, and that's what they'll talk about all the time. Sudden onset.
Yeah.
Sudden onset of vertigo. That's not a thing. Like that could potentially be a stroke. So
I brought in one once. We went straight to CT, came back. Dr. Joe was on, and he's like, "It's not a stroke." I mean, 3 minutes, he'd done his assessment. It's not a stroke. Sure enough, it wasn't. But she had severe inner ear problems.
that's part of the things though
That's what
where I
he's
say I would much rather y'all
That's what he's an
say it's
idiot.
a potential stroke than not.
Me too.
Yeah, I didn't know he was gone until he was
I have some
gone.
extras of these. I'm just gonna leave them on the
It's been a
table.
while.
It's just like a little packet. So, I
Because,
mean,
you know, I'm just, well, I just don't want to see it. And there's somebody talking about it. It's like, what the heck is that? I never actually heard this.
thank you guys.
Don't
Talking
forget
about
the
the
mic.
education thing. Thank you.
Thank you guys.
I was given an education thing once, not long ago, actually. This fall, last fall. And it told how many pages of classes.
You
were
leaving the
there.
candy? Hey, Tim, you had stepped out, but he had looked up that you can give tea in case they're out.
That's what he told
Are
me.
you leaving the candy? Yeah, that's y'all.
No,
No.
no. Thank you, please.
Hey,
Okay, I'll